Thank you very much, Kathy. And if Tim thought it was hard to follow Lincoln, just, imagine how humbled I feel. Really trying to perhaps illustrate my own little bit of weaving, so eloquently described at a very local system. I'd like to try and describe a little bit about what we're trying to do at a national system to try and get some of those flax shoots woven to nurture the kind of conditions that we want for integrated care. This is just to remind you that before there was Dunedin, there was Edinburgh in Scotland. And this is where I have the privilege of being based, but I work across Scotland. And sometimes it could be hard this week to think, am I in Scotland or am I in Kaffia? I think we have very many similarities across our countries, both small but perfectly formed, and both really trying to be very creative and punch way above their weight. I was very struck by the plenary session yesterday and the conversation about health equity. And sadly, in Scotland, we face very similar challenges with inequalities, very starkly illustrated by this underground map schematic showing that the difference in life expectancy that you can experience travelling from the leafy suburbs in the west of Glasgow to the east end of Glasgow, where the life expectancy for young men is far too short. We don't perhaps have the same cultural diversity that I've heard about this week, but you may have heard the conversation that we had last September in Scotland, where we were thinking about what kind of future we wanted for ourselves. And certainly that has really liberated the conversation and I think activated a whole cohort of society around thinking about self-determination and what future we want to have in Scotland. Tartan is probably our equivalent of weaving, and in Scotland, our tapestry, our landscape for health in Scotland is woven of 14 geographical health boards, each with their own identity. Sometimes it feels as if each with their own element of tribalism. And I recognise the conversations this week about your own DHBs and the conversation about exactly how many DHBs does a population of 5 or so million require. We have a population of just over 5 million, and around 12 billion pounds sterling is the health and social care budget. We are trying to align 14 NHS health boards with 32 local government authorities, and traditionally local government has had the responsibility for housing, for welfare, for social care. But we're on a journey now to join up that health care and that social care with new legislation for the integration of health and social care, really so that we can get better at joining up the conversations that we heard about from John and the wider team, joining up the health and social care around the needs of people. We've got a fairly open road now. We've just had the legislation passed last year, so some of the roadblocks have been removed. That's an open road. And in a sense, what we need now for our journey is a compass rather than a very detailed sat-nav. And we have some of that compass in that the World Health Organization have just launched their people-centred and integrated healthcare strategy. And I'm delighted that they launched that in Edinburgh at the international conference that we hosted in March of this year, and some of the colleagues in the room were present with us in Edinburgh for that celebration. And that's really looking at the 5 domains around person-centred and integrated healthcare. And I think for me, one of the most important of those domains is centering around the needs of the individual, but empowering people to be part of the solution. And I think I've heard lots about that over the last 24 hours. We're also able to draw on the evidence from the international community, some of which generates from New Zealand as well. And again, there are people in this room who have helped generate some of the evidence base around integrated care. And we know that there are 7 important lessons if you're going to design good integrated care. And the first is probably the most important one. Start with population health. Start with the needs of a local population. Don't start with the services. And that's something that we're trying very hard to keep at the heart of our approach to integrated care in Scotland. We know that there's some differing models across the rest of the UK. In Scotland, we are proud not to be doing it the same way that they're approaching it in England. And we are also really delighted that the King's Fund document, which compared and contrasted different models of integrated care in the United Kingdom, highlighted that in Scotland we seem to be going further and faster than the other administrations in the UK. And I think part of that is because we've not just looked at the structures, we've not just looked at the governance arrangements, but we've actually really had a conversation about the professional, the cultural, and the behavioural issues. And we heard so much about that yesterday from Helen around the cultural and human dimensions to organisational change. We've also positioned our approach to integrated care in the context of a new paradigm that we're approaching around health and well-being. And I think it's fair to say that for so long, health has sat in that old world, that old paradigm of episodic care, hospital-centric, hopefully all of that being an anathema to the Royal College of General Practitioners of New Zealand, but something which sadly much of health has still been grounded in that disconnected care. We want to move towards a future paradigm, not just where care is integrated, but where there's a real focus on preventative and anticipatory care and supporting people to live good lives. So in a sense, while we don't have a detailed sat-nav, we do have a route map which is helping guide us on our journey towards better outcomes in Scotland. And I think the themes of this conference resonated with me in that it's got to start with imagining a shared vision and then conversations that inspire people to connect with that vision, to commit energy towards making the change, building capacity, capability at all levels, in all teams to make the change, and using not just technological innovation, but social innovation to design new models of care that use the local people, the assets and the talents of the local community, as we heard about in CAFEA, as well as building on the talents of statutory services. An integrated care that is really grounded in that interdisciplinary team, where the person with the right skills does the job, regardless of what uniform they wear or what their professional discipline is. Building on that interdisciplinary team where people, carers, unpaid carers, family carers are part of the team as well as the professionals, and connecting those teams across care settings and across agencies. And I think it's only fair to say that this reform of health and social care in Scotland sits in a much wider ambition to reform our public services. Our pillars of our public service reform are based around prevention, partnership and integration, but very much around empowering people. Our integration legislation is a part of a wider set of legislation which includes self-directed support and also the community empowerment as well. And I think it's only when you see it in the round that it begins to make sense. It's really about making sense and meaning to people. It's that what matters to me outcome that we're really trying to chase. And we know from speaking to people in Scotland about what matters to them when they're living with multiple conditions. Jessie from Dalmellington with her practice nurse Evelyn tells us that it's about coordination and continuity of care. That's what integration's about. It's not about legislation and structures. It's about those trusted relationships that we've just heard about. And it's about being able to get better access to information, advice and support to live well, and understanding and being confident that staff working together will communicate well together and will be able to share information across the team and across agencies. So our approach to integration is grounded in what matters to people, and it's also part of our overall vision for quality. On Thursday, we had an excellent quality symposium day here where we talked about safe, effective, and person-centred care, and our vision for quality has integration as part of that overall vision to help people to live well, live longer, healthier lives at home. Some of the weaving that my team and my colleagues in government are working on is to try and get our policies aligned so that there's a coherent, visible basket that makes sense and that we're not confusing people with a whole lot of different policies that are pulling them in great different directions. So it's important that our policies from primary care to self-management to housing to active and healthy ageing to living well and dying well are all coherent and are all creating the conditions for integration. It's equally important that our focus on delivery makes sense, and again we're looking at that triple aim of improving the quality of care, improving the health of the population and delivering better value and ensuring that we've got sustainability of care. So integration is one aspect of our 12 priority areas that sit underneath that triple aim. I particularly like the pyramid triple aim in New Zealand that has equity as part of that triple aim. We're also conscious that we need to get to that new paradigm by getting to what we describe as the third curve. For so long, we've spent in the performance box. And again, we discussed yesterday how negative, how sapping in energy it can be when all we're focusing on is performance targets. We've made some great progress moving towards an improvement approach, an ethos of continuous quality improvement that is driven and led by practitioners, but we need to do even more to get to a point where that's truly co-produced with all partners from all sectors and is grounded in what matters to people. Some of our improvement tools are very, very standard. They're the plan, do, study, act, test of change. But some of our improvement tools are also more innovative, where we're looking at reflective practice and changing the conversations so that the conversations are much more focused around assessment of what matters to people. So, for example, our talking points approach. We support practitioners to learn together and to learn across Scotland what works, what's not working, what could be done differently and smarter through an improvement network, which is a very loose collaborative. It's not an over-prescribed collaborative learning programme. It's much more emergent and almost functions as a social movement and has all the usual support for learning and improvement methodologies. At the heart of our work, I think we have to place leadership in a distributed model at all levels within the team, at all levels within the health and care partnership, and at national level as well, so that our policy leaders and our politicians are leading from the front. That's going to take quite courageous leadership when we are living in the fiscal environment that we're currently living in. And I know that you recognise, having heard the conversation with the Minister yesterday morning, sometimes taking small steps of change is not going to be enough to make a difference. Sometimes it's about taking quite big, courageous steps. And I think the young man that started off the morning letting it go, learning to let go, is something that I encourage my colleagues to give over some of the power. We know that the fiscal climate is not going to get better for quite some time. That Bermuda Triangle of multiple billions of pounds that are not going to be able to be back in the system for a good 10 years is something that we're all going to have to plan for. Our demography is as challenging as it is in New Zealand when we look at the growth in the over 75s and the over 85s in the next 20 years. And we know as well that there is an atlas of variation in terms of some of the practice. This is a graph of the numbers of bed days that are associated with over 75s in different areas of Scotland. And we know that there's quite a postcode lottery, depending on what part of the country you're living in. We also know that that variation is not just across hospital care, but it's also a variation within primary care. That's an example of some of the non-anonymised primary care data that we're starting to look to use to challenge and provide some peer support and challenge around improving practice. We've used data to try and lever change, but also using simple data as a call to action. This is, I have to say, almost a back of an envelope calculation, but a very elegant calculation that was done a number of years ago. And the red graph shows the rate of hospital bed use for over 65s based on the practice in 2007. And then if you superimpose the population changes over the next 12, 13, 14 years, you can see that if we still continue to do what we were doing then, we would have needed to build a new district general hospital every 3 years. That was a wake-up call to politicians, to managers, to professionals. Nobody wanted to do that. It wasn't affordable or desirable. So what did we do? We took forward then our Reshaping Care for Older People programme, which is a 10-year programme, and we're just into year 5 of that programme. We levered a little bit of change fund, which was not exactly new money, but additional uplift monies that was ring-fenced for the purpose of doing something different. And the something different that we did was, instead of health deciding how that money was going to be spent, the 32 health and social care partnerships had to sit down with housing partners, with our NGOs, and with the independent care at home providers, and with older people and their carers to develop a change plan that was going to do something different. And one of the things that was different was supporting unpaid carers, family carers, for the first time, that there was a sort of real target to invest in unpaid care support. We gave fairly simple rules. It wasn't overprescribed what they had to do. This is the what that we know works, and what we asked them to do was to move away from the green stuff, which was all about institutional care, and invest more in the blue stuff, which is around preventative and anticipatory care, to change the locus of care from hospital and care home to care and support at home. Here's what we've achieved. We've achieved over a 10% reduction in the rate of emergency bed days for over 75s. And some of the other big headline figures are also quite compelling. That's 2 million more days spent at home by over 65s last year than we would have expected. And it's not just a shift from hospital to care homes. There's fewer people also resident now in care homes than we would have expected. But that's not enough. We still have to go further because we know that it's not just all about older people. Multiple morbidity occurs in the population that have socioeconomic deprivation 10 years earlier than it does in the more affluent populations, and particularly the association of mental and physical comorbidity we know is a real challenge in our particularly deprived communities. So our integration approach is not just about older people, it's about all adult care groups, and if the authority wants to, they can also look at integration for children and criminal justice as well. We've got some fairly simple principles, but the real crunchy deal breaker I was just chatting to Kathy about earlier on is the approach to integrated budgets. If you remember, I said we had about 12 billion in the budget for health and social care for adult services. If you look at the second chart, the smaller chart, that shows the proportion of that budget that is going to be delegated to the integrated authorities. That's not tinkering at the margins. This is big scale change. And importantly, some of that delegated budget is the budget that will commission emergency services. So for the first time, primary care in Scotland is going to have a much more significant leverage around the emergency pathways in through hospital and back home again. So I'm confident that that's going to lead to a scaling up of some of the new models. We're trying to take a fairly light touch towards the management and the measurement of outcomes, not the 26 different high-level performance targets that we used to have, but 9 health and well-being outcomes. And I'm really encouraged to hear that conversation coming through in New Zealand as well, where you're looking at a lighter touch towards the number of outcomes that you'll be measuring. What I really like about our approach to outcomes is that this is about personal outcomes. Our 9 health and well-being outcomes are translated into actual stories, what that would look like to people and communities, so that this sort of I matter kind of approach. And here's what some of our local partnerships are telling us is happening on the ground. North Ayrshire have the privilege of being the first to have developed their strategic plan, and they're describing their journey. What worked well was really getting that shared vision and common objectives agreed across the partnership, and really thinking differently. A lot of the work that we did around reshaping care for older people has actually laid the foundations for different conversations, different relationships. Similarly, their neighbours just a little bit further south, that's South Ayrshire, that's Burns country, Rabbie Burns territory, they've described their journey towards integration as a 4-year journey, really. And lots of that journey has been about engagement and visioning and involving people to help shape what the future looks like. In my own local area in South Lanarkshire, where the administrative centre is Hamilton, our South Lanarkshire partnership is really taking an approach which is about building local networks of care and support. Again, very similar to the conversations that we heard earlier this morning. And that they've stolen the strapline, no ward like home. And I think that's beginning to get some real currency back home, that people understand that home's best. Hospital when you need it, but back home as swiftly as is possible. Some of my colleagues in Forth Valley in the Stirling area are describing these local networks as concentric circles that you wrap around the individual in their own home, the practice, the extended primary care team, and then that whole system. But it's the people. It's not about the structures. It's the people that are going to make the difference. And for me, I think that one of the most important enablers around this whole journey is going to be the workforce strategy. Everyone matters is our workforce vision, and we've all got to look at working differently and valuing a different relationship between professionals. We're looking at that whole team approach, and we're looking at how people themselves, people living with long-term conditions and peer support networks are part of that whole system team, using technology as well to help connect some of the peer support. The concept of community coaches or community connectors obviously resonates from CAFIA to Scotland, and some of the models that we're wrapping around our general practices include the concept of a link worker, who might be someone from the local community who's had some support and training to be a health or a lifestyle coach, and could provide some really important signposting for people in and around the practice. Or partnerships with our national charities like Macmillan Cancer Support or Alzheimer's Scotland, who are doing a lot of fantastic work in building dementia-friendly communities. Connecting people using social media, and there's been a really exciting social movement around dementia carer voices, where people have been tweeting and making their pledges, a bit like what Helen described around the NHS Change Day. We've had a similar focused approach around support for carers who are caring for people affected by dementia. One of the exciting models of care that I think we could learn together across Scotland and New Zealand is the House of Care. I was sat next door yesterday afternoon hearing from Midlands Health Network what they're doing around some new models of primary care practice, and it's very similar to what we're doing in Scotland around the House of Care, or adopting the Year of Care holistic assessment and care planning approach. We are very much, as I described yesterday, looking at, or on Thursday, looking at using technology to enable integration across the professional team, but absolutely using technology selectively and not losing the human touch and the human dimension. If you're interested in hearing more about how this works, then I do have a workshop tomorrow where I can go into a little bit more detail about some of our approach to risk prediction and anticipatory care planning and medicine reviews that happen around the practice, and how we've levered our contracts for independent practitioners for GPs and pharmacists to make some of this happen. Another aspect, another strand that I will talk about tomorrow in more detail is our approach to intermediate care, care at the transition between hospital and home, where we're trying to provide realistic alternatives to emergency admissions such as hospital at home, and more rapid and enabling home care support to help people recover their skills and their independence again after a period of illness. Some of the emerging evidence from our hospital at home models, particularly the more mature ones like this one, which has been in place now for over 2 years, is showing the significant reduction in emergency admissions that the hospital at home team are now delivering, with about almost 80% being able to be supported at home as a realistic prevention of admission, to the extent that actually we've been able to close some hospital beds on the back of that. I'm here because my rehabilitation ward is now closed. We don't need it. We've got our hospital at home and supported discharge teams now providing what used to be done in hospital in community settings. We described the route map at the start of the talk, and we're now really in a position where we can look at the different partnerships across Scotland and begin to get an understanding of the critical success factors. I'm sure those critical success factors for our partnerships will be no different for the success factors in your system. And if you do want to know more, then get on the bus with us and join us on this journey, and see if we can perhaps get some knowledge exchange and shared learning going across our two systems. That's some web web-based resources that you can access if you want to take a deeper dive into some of the areas that I've just signposted you to. There's lots of material on our Scottish Government and our Joint Improvement Team websites. And if that's not enough for you, then come over and see us, because we'd be glad to make you very welcome. Thank you very much.
Okay, we're almost on time, but are there one or two burning questions anyone has? At the back, Vivian?
Area, and one of our concerns is with the move for hospital to home sort of thing. What do you do when the home environment or the housing is in itself probably a major contributor to why they got into hospital in the first place?
Yeah. That's a really excellent question, and the hospital at home service that I illustrated is actually in one of our most deprived communities in North Lanarkshire. And one of the things that they've been able to benefit from is that groundwork that we did with our housing partners over the Reshaping Care programme. So instead of housing sitting over there and being quite difficult to access, they are now round the table in the planning and are able to give us rapid access to some of the equipment and adaptations that are necessary for people to be safe at home. But the reality is there are some housing situations that are just totally toxic and nobody's going to recover in them. So that's why we make judicious use of our step-up or step-down beds, which offers a vulnerable adult a place of safety to have their recovery.
Hi, my name's Alistair. I'm a GP on the North Shore. My question is regarding the multidisciplinary approach to integrated care. I think generally people are very supportive of the idea, but when it comes to the reality and people start seeing sort of increasing nurse prescribing, increasing services being divulged to pharmacy, talk of physios signing off medical certificates, that starts to concern some doctors in terms of feeling like the profession's being eroded. What would you say to those doctors in terms of the way forward?
I've really practiced that model of multidisciplinary care all of my professional career as a geriatrician, but it does take time for people to get used to sharing the assessment and the relationship. I think we heard this morning a very eloquent description from John and colleagues about building trust and relationships being really the foundation for good interdisciplinary practice. I had the privilege of being in Hawke's Bay for a couple of days before I came through to Hamilton and saw at first hand that happening in the care clusters that are being developed around the practice teams in Napier and Havelock North. So it does take time, but the rewards and returns and the outcomes that you get are worth the investment of that time.
Last one.
Hi, my name's Rose, I'm from Taranaki. I loved the word crunch time, which was your budget slide, where you got money out of secondary care. We've been told for 10 years we need to do more services, and we're happy to do them, especially working with lots of teams, but there's no funding for it. I've been doing quite a lot of palliative care for free because the people aren't dying of cancer, they're dying of liver failure or heart failure or emphysema, and the secondary services won't come to the house. They don't meet the criteria. We get a letter back saying no. How did you get the money out of them?
I'll come back next year and tell you about what proportion of that money has actually shifted. However, I think we're already seeing really good examples of where hospital secondary care practitioners who were previously only working in hospital are now coming out. And they're not coming out and charging a fee for coming out. They're coming out because it's the right thing to do. It's giving the right care in the right place. What I am finding is that those who do start to come out bring 5 more with them because they are just so energised and humbled by the experience of working in community settings. And I think that it's now lit a flame in the profession that I don't think that flame's going to go out. So I think the money will follow the workforce.
Hello, I'm a GP here in New Zealand, but I was working in Scotland. When you said a 12 billion budget, is that pounds?
Yes,
So
pound
roughly
sterling.
24 billion New Zealand dollars, roughly.
Yeah.
And the health minister on her first day talked about 20% of the government, hang on, I've forgotten, but $1.7 billion was the health budget, which represents 6.7% of the New Zealand GDP. It's a very different amount of money, or am I missing something?
I think that's maybe a question more for Kathy.
Okay. It's interesting the comments about the budget because, as Anne said, I was very interested in the budget slide as well. I was fortunate enough to spend some time in Scotland in April, and one of the things I was looking at was exactly what Scotland is doing about uplifting the budget and putting it into the integrated buckets and redistributing it, as we all know and the Minister referred to yesterday. From him down and up again, everyone's frustrated in our lack of traction in that area. So, as you might have seen from the leaked documents, one of the things that Murray and Sue were focusing on in the review processes was, again, what we might be able to do about that. And there are a number of ideas on the table, some of which will be popular and some of which won't, but we'll see where we go with that. But, you know, certainly it's a live question that we all struggle with. Thank you, Anne, very much for your contribution. And I think in the last